Hello, and welcome to the Purview webinar. This is the second in our series on oncology. My name is Les Trackman. I'm with Purview. Let me go through a few logistics first, and then I'll introduce our panelist speaker for today. First of all, for all of your participants, your microphones will be muted. The session will be recorded, so you'll get to be able to review it later if you missed anything or if you want to share it with any of your colleagues. If you have technical issues, like we had a few of this morning, we suggest you log out and log back in. That's usually the best way to go about it. And if you have questions for our panelists today, please add them to the chat at the bottom of your screen. So this is, as I said, this is the second of our series of webinars focused on cancer and the role of second opinions in fighting this dreaded disease. As you know, cancer impacts way too many people. Each of us has been affected by either our own disease or that of a friend or family member. In fact, on Monday morning, I received a note from a woman who was locally diagnosed with cancer, who told me that she was too ill to travel to see the specialist who might be able to help her out. And she inquired if we had any information on where she might look to get some kind of assistance. Here at Purview, we've also been impacted by a close friend and business associate of ours succumbing to cancer at way too early an age. If you've heard us at Purview talk about the Mike Shane Memorial Fund, you know that was started as a reaction to the premature death of our friend Mike Shane, who was taken from us by the dreaded disease cholangiocarcinoma. And while treatment in general for cancer has come a long way in the last few decades, we still don't have this disease licked by any means. We at Purview, as a vendor of platforms focused on enabling hospitals to efficiently deliver expert second opinions in areas including things like oncology, we've been amazed to hear the statistics of how important second opinions can be. The Mayo Clinic did a study of second opinions it delivered and found that in over 80% of the cases they reviewed, required a change in diagnosis or a modification of treatment for the patients in that study. So what should a patient do? And when should they do it? And if you're an expert physician focused on a particular disease, how do you efficiently deliver your services to the patients in need of your expertise, even when they're not necessarily local to you, like the woman I corresponded with yesterday? These are some questions we're hoping to get closer to answering in this webinar series. I'm honored to have with me today for our conversation, Dr. Thomas Schwaab, who is Roswell Park's Chief of Strategy. Roswell Park, if you don't know it, is located in Buffalo, New York, and was the very first center in the entire world to focus exclusively on cancer, and has been recognized and designated as a National Cancer Institute Comprehensive Institution. In addition to his role in strategy, Dr. Schwaab is an associate professor of oncology, focused on urology specifically, and the CEO of RPCI Oncology PC. So please join me in welcoming Dr. Thomas Schwaab. Dr. Schwaab, we've got a diverse group of attendees and those who have signed up for the live or the recorded session. So let me start by asking you to describe Roswell Park in general, and then a bit more about the work that you do there and maybe some of the work done by your colleagues.
Good morning, Les, and thanks for having me, and good morning to everybody else. So yeah, Roswell Park, as you mentioned, was the very first cancer center founded in 1898 by Dr. Roswell Park. That's where our name comes from. And Dr. Park really envisioned that he would be able to marry the patient and bench-to-bedside research under one roof. And that's really the mission of what we still do today. And, you know, ideally, that's how any NCI designated comprehensive cancer center is supposed to work. We are actually one of the first three inaugural cancer centers that were designated by the NCI in the 1950s. And so Roswell Park is a licensed small hospital with licensed 157 beds. All, you know, we're one trick pony. We all focus only exclusively on cancer. We have a growing community presence in Western New York and a growing affiliate network throughout really the Northeast by now. My role at Roswell is, that's why you see me in scrubs. I'm a urologic surgeon, and you know, the larger amount of my time these days, I am the Chief of Strategy and Business Development at Roswell. So I'm really in charge of trying to anticipate what Roswell is going to look like 10 years from now. And I'm in charge of this kind of growing community and affiliate network footprint that I mentioned.
That's great. I'm going to ask you a little bit more about that later. Maybe you can paint us the picture of what it looks like 10 years from now. I know you're very busy and you've got a lot of things going on, a lot of things that you're juggling. But I wanted to focus back in for a minute on second opinions. I am sure that you and other physicians at Roswell Park, due to your specialty, get the question of a second opinion from a patient that's not initially a Roswell Park patient. How do you deal with that? How do you handle those requests?
So first of all, even my own patients that may come to see me for their initial opinion, if they ask me for a second opinion, I always encourage a second opinion. I think it's number one, it's important for the patient's kind of personal mindset, in particular if the diagnosis or prognosis may not be good. So simply having a second expert opinion in many instances will settle their mind and allow them to come to grips with the reality. It is every patient's right to have a second opinion. So I think that's absolutely critical to appreciate and understand. But for me, I think modern oncology care is all about coordinated care and access to subspecialists. So by now, just having prostate cancer does not mean that you have prostate cancer, but there are different flavors of prostate cancer, different clinical situations. Just having kidney cancer, which is my specialty, does not mean that you have just kidney cancer, because there are different flavors of kidney cancer. So you need to have access to first a specialist that is really able to diagnose the cancer appropriately, and that lives and starts with the pathologist. So you want to have access to truly subspecialized pathologists, which in some instances is not really that critical. Let's take breast cancer, for instance, or kidney cancer. The pathology itself is relatively straightforward under the microscope. But in other instances, let's take sarcoma, it's absolutely critical to have your pathology reviewed by a subspecialist with focus on sarcomas. The second piece then is to have access to a multidisciplinary care team. Modern cancer care these days really is focused on multidisciplinary care. So you want to make sure that you have access to the medical oncologist, the radiation oncologist, the surgical oncologist, and ancillary services like genetic counseling, molecular testing, what we call survivorship. When you've been treated and hopefully cured from your cancer, who's going to manage potential side effects of the treatments, things like that. It's really not just treating the cancer with chemotherapy or cutting it out or radiating it, but it's truly a multidisciplinary approach. And that sometimes is challenging to find in community settings. That's obviously where NCI designated comprehensive cancer centers come in, but that's also the benefit of a second opinion.
Great. So, so let me see if I can unpack a little bit of that and give some advice to some of those in our audience, both providers and patients. In the process of getting a second opinion, let's say, for example, that somebody comes to you and says, Dr. Schwaab, I've been diagnosed locally with kidney cancer. I know you're a specialist in we'll call it a narrow subspecialty that I've been diagnosed with. What do I need to give you? What do I need to bring to you so that you can perform that second opinion? And then how many of those tests get done locally at your facility?
So obviously that will, the information needed to provide a second opinion will vary from cancer to cancer, from clinical situation to clinical situation. But ultimately every facility that specializes or focuses on second opinions will have an intake team that knows exactly what they're going to be asking for. So the first thing they're going to want to know is patient information, right? Are there other medical issues? Does the patient have any heart issues, any lung issues, things like that? Obviously, any medications, allergies, the standard intake that you would give at your family doctor as well. The second piece is any x-rays tests that have been done or performed in this context, not going back 20 years, but in this particular context would be important. And then if there's been any tissue diagnosis made, We don't look for the reports from the local pathologist or the local radiologist. We insist on the actual images to be reviewed and the actual pathology slides, the actual specimens. They have to be submitted and then reviewed by our pathologists.
Yeah, so I was going to ask that question, whether you work on digital pathology or you need the actual analog slides, but you say the analog slides are preferable.
Now, with that said, digital pathology has really come a long ways over the last 5 years or so. So yes, we can start with that. It's not always that easy to find collaborating organizations that are more than happy to share digital pathology slides. One of the reasons why you need the actual specimen is many times the actual additional subspecialty pathology work depends on additional immunostains, depends on additional molecular testing, things like that, where you need the actual tissue as a specimen to work with.
Got it. So let's say that a patient in this particular case travels to Roswell Park, and we'll say they bring with them, or maybe they send in advance their records. How do you deal with the continuing care of that patient when they return back to their hometown, let's say, for example?
Yeah, I think that's important because the continuum of care is really, really the key here. Because many times patients will travel and all they want to know is the provider that gave me my initial recommendation. Does the provider know what they're doing? Is that the right recommendation? And, you know, the vast majority of time, absolutely, it's the right recommendation. That's what we have, what we call the NCCN guidelines and many other clinical guidelines that we are supposed to follow. And so as long as you follow the guidelines as a physician, the patient will get the appropriate level of care. With that said, a lot of, thanks to the pandemic, a lot of our second opinions by now happen in a virtual fashion. So, you know, that's why you see me in my office right here. Many of my virtual visits, many of my second opinions are happening in a virtual fashion. With that said, when the patient comes in, the first question that I will ask the patient is, what do you want out of today's visit? Are there certain questions, concerns, fears, worries that you want to make sure we talk about? Because they already know their diagnosis. And sometimes it will vary. You know, some patients really want to know about all their different treatment options. Other patients already decided on one particular treatment option, and they want to know more details about that particular treatment option. Again, the vast majority of time, my recommendation will be the exact same recommendation that their local physician provided, and I will be very clear about that. And you know, then when the patient goes back to their original physician, you know, it's an easy phone call to say, hey, listen, I saw your patient. I heard you recommended X. I recommended the same management. Good luck. And, you know, the patient is satisfied usually in that context.
Is there any kind of ongoing tether that you would have with either that patient or with that local physician in the continuing care?
It depends on the clinical setting. So if it's a complex patient that may require additional treatment, I would then recommend, hey, listen, let's have your surgery done by your local provider. Make sure when you have recovered to come back to see our medical oncologist, radiation oncologist, whoever it is, for additional management. Many of those managements with our now existing network, we can then coordinate in the network setting so that the patient doesn't have to travel hours and hours to come back to Buffalo.
Great. Like the woman who contacted me on Monday, she wasn't in a position to travel. So if in fact she got the treatment, she would love to get the care taken at her home or at her current location. Let's talk a little bit about timing. So you're obviously a specialist and your facility is a specialty facility. When would you expect, or when would you recommend that a patient who has an initial diagnosis of cancer, when would you recommend they reach out for a second opinion?
That may be one of the most important questions you're asking me today. As soon as the patient has the diagnosis, there should always be 24, 48 hours, many times 5 days, 7 days, for the patient to make sure that they get the comfort of a second opinion. It is extremely rare that a patient is diagnosed with a cancer where the management has to be implemented within the first 24, 48 hours. acute leukemia may be one example, right? But most of the time, there really is that management is limited to a very small subset of cancer centers anyway. But for the broad variety of cancer diagnoses, the patient has the luxury to take a step back, Google on the internet if they wanted to get additional information, find a second opinion. It is extremely rare that treatment has to be initiated immediately. In particular for cancers that are localized cancers, what we call usually stage 1 or stage 2 cancers, treatment can be postponed until you really have a very good plan forward that you're comfortable with as the patient.
Great. And you've already said, you must be reading my mind on what you do if one of your patients asks for a second opinion or suggests a second opinion, or as you said, maybe you would even suggest to them that they get a second opinion. Do you see that wholesale in the medical space? Do you see doctors generally predisposed to positively predisposed to suggesting second opinions, or are there still doctors that find that as offensive to them?
I would think that varies. As a good physician, you should never be offended by a patient questioning your expertise or recommendation, because again, I don't think the patient is necessarily questioning your expertise, but for the patient themselves, in order to come to a full understanding and acceptance of their diagnosis, they would ask for a second opinion. So I don't think it's really about and it should never be about the doctor's ego, by the way, or pride. It should always be with the patient at the center of it.
Got it. Great. So I misspoke at the beginning of the session. I said you should type in questions into the chat box. There actually is a Q&A box on Zoom that you can type your questions in. We'll start taking audience questions in just a minute. I have one last question for you, Dr. Schwaab, and then I'd also like to talk about any specific research that you are doing there. But the question I have, and you touched on it already, is in the we'll call it post-COVID world, hopefully with our fingers crossed, we are in that situation now. Is anything changed from a we'll call it a second opinion world, or even from how Roswell Park operates? Has telemedicine become more important in general? And are these virtual second opinions, are they predominating what you get? How has that been affected?
Well, the pandemic changed a lot of how we do clinical work. So for instance, a lot of my kind of regular patient follow-ups are done in a virtual fashion, because for me as a surgeon, the follow-up really is dependent more on the imaging findings post-surgery rather than the physical exam findings. So, we do a lot more virtual visits post-surgically or in the post-acute care setting than we used to do. I do think that most patients still feel more comfortable seeing the physician in person, but that's going to continue to change, and we're going to see a lot more virtual visits going forward.
Do you do at Roswell Park, or do you personally do any, I'll call it a pre-consult kind of reviews? Do you ask patients to send you documents in advance and say, yes, it would be appropriate for you to come here for a second opinion? Or do you just do that all in one bulk time?
We tend to do it all in one whole time, simply because I think it's clearer to the patient and the referring physicians as to what the intent of the visit is and the service piece to it. The big thing that we do is we service our network affiliates with our tumor boards. So the second opinion may not be with the provider per se, but it will be with the entire tumor board done in a virtual setting. And many times it's actually the provider themselves saying, I want to present this patient, rather than the patient saying, I want to be seen in a virtual visit. So we don't necessarily always touch the patient. We allow that to the local treating physician to have the luxury to present in our tumor boards, and then the patient still gets the benefit of that second opinion, so to speak.
That's great. Thanks for that. So let me take a few questions from the audience now, and then before we close, I'd like you to just give us some more information about some of the things that you guys are involved in there, and then also maybe talk about your vision for the 10 years in the future, what it might look like, whatever parts you can share of that. But the first question that's in from the audience is, what are the important elements to cover during a second opinion appointment? Now, I'm assuming that's, I'll parenthetically say, I'll assume that's from a patient's point of view. What are the things that should be covered? But maybe you can answer it from both sides.
Well, the way I think of a second opinion is it's just another doctor visit. It's just with the focus of you already have the diagnosis, the patient kind of has come to grips with it, and now it's a matter of talking about what are we going to do. So think of it as a regular physician visit. The physician still needs to understand the patient. Is the patient sick? Are there any comorbidities? What's the patient really focused on? What's important to the patient? And then I think we spend a lot of time explaining the diagnosis, explaining the prognosis, and then talking about different treatment options. If you come to a place like Roswell, one of the pieces to talk about are what are all treatment options that are recommended by the guidelines, and are there any clinical trials available that would benefit the patient?
That's great. And is there a way for you or the patient to keep up to date on what the clinical trials are that are available? Do they come to you with suggestions? Hey, I heard about this clinical trial at Dartmouth or something like that.
So obviously we have our own kind of portfolio of clinical trials that we're supposed to be aware of. And then if a patient says, hey, listen, I read on Google, this and this clinical trial is up, many times we'll look up the clinical trial ourselves and say, yeah, that may make sense. Or you know what, I don't think that you're eligible for that patient, for that trial.
Okay. There's another question that came in from the audience. This is a long one. I'll try to read it, but and I'll summarize it as I go. How do you handle internal buy-in for second opinions at Roswell Park? Has there ever been a challenge? What about too many words? I guess are there differences of opinions within some of the team, and maybe even from a tumor board there at Roswell Park?
Yeah, so the concept of a second opinion, in particular, if it's virtual and the patient doesn't necessarily come on site, is novel. And so not every clinician is comfortable or really buys into that concept. There are some cancer centers that some of their faculties do is they provide virtual second opinions. They don't ever see a patient on site. That's not for us. We kind of pick and choose some of the more, let's call it, engaged clinicians that are willing to engage in these second opinions. Part of the issue is that if the patient comes and just gets confirmation about their treatment recommendation and then goes back to their original provider for their subsequent treatment, for me as the physician, I only get to meet that patient once, and I'd never get to build a relationship or benefit from, a clinical trial enrollment. So it's not every physician buys into that concept.
Got it. Okay. There's a few more questions, but I'd like to take just the last remaining minutes to have you talk a little bit more deeply about some of the specific things that you all are involved in at Roswell Park, any specific research that you're engaged in personally, and then maybe your vision of the future, what the future might look like.
Yeah, so real brief. Things are changing tremendously in Roswell. Not only are we growing a affiliate network that is going to span all of the Northeast and hopefully expand throughout the country, with the idea that we would like to bring Roswell Park quality care to as many patients as possible, rather than having the patients come to our brick and mortar, so to speak. For us at Roswell, we've started to invest very heavily in cellular therapies. Our new deputy director and chair of medicine, Renier Brenchens, is one of the inventors of what we call CAR T-cell therapy, which has completely revolutionized the way leukemias are treated these days. And so we're really spending a lot of time and effort on building out a truly innovative cell therapy program at Roswell Park. It's going to be the focus for us going forward on a lot of clinical trials and solid tumors, obviously, as much as liquid tumors as well. Where I see the future for a standalone cancer center like Roswell is, how do you continue to create value for patients, for referring physicians, for payers, for self-employed or self-insured employers? How do you create value so that people still continue to see the quality of care that we bring to the table?
Great. Well, thank you so much for your time this morning. We very much appreciate you sharing. As I mentioned to start out with, this webinar is being recorded, so this will be available on our website shortly after the conclusion of this. If you'd like to take a second look at it, or if you want to share it with one of your colleagues, please direct them accordingly. Again, thank you so much, Dr. Schwaab. We appreciate your participation, and we will see you again soon. For those of you in the audience, we have two upcoming events. One that's listed on your screen right now is the live Q&A on cross-state licensure. So this is a big issue that we found from a lot of hospitals, providing second opinions to patients outside of their own state in which most of their providers are licensed. That's a very important webinar coming up on the 25th. We've got some groundbreaking research that we've done on that. And then we also have a specific seminar related to children's, in this case, cancer, but children's second opinions that's coming up on Thursday of this week. So thanks again for joining us, and we'll see you again on the next webinar at Purview.